Hi, Joe. Thanks for joining. Thanks, everyone, for joining. We're just waiting to see if there's any others. Oops. I hope you've been having some good celebrations so far for National CNS Day. It's been great to see a lot of Twitter feed already going on, commenting on various work going on in the trust. Brilliant.
Just to say, we're recording this so that anybody that can't join at lunchtime can watch it later on at any point, and we'll get it uploaded.
And then Claire, you've got the presentations and the videos and bits ready to go. Brilliant. Thank you very, very much. Okay, well, just aware of time and everyone is so busy. So shall we start the session off? First off, I'd just like to say thank you all very, very much for prioritising today and joining the webinar. It's fantastic to see so many of you here online. I hope you've all got a sandwich or a cup of tea or something to be able to stop and to enjoy the session with your colleagues from across the Alliance. So this webinar is meant to be about celebrating the success of the cancer CNSs across TVCA. We wanted to highlight some of the good work that you've all been involved in. And there's also going to be many other examples that aren't actually shared here today, but these are just a few, and you've highlighted one from each trust. And we're very grateful for those teams for stepping forward and actually doing a presentation on their work today. It's also just a nice opportunity to be able to sort of meet with other colleagues, have a bit of time, hear about good work and sharing of good practice. Often we don't take enough time out in our day to actually sort of hear some of the good things, and hopefully this might share or stimulate other conversation with colleagues to help with some of the work that you're doing. I also just think that CNSs, you're actually at the heart of everything that's going on in a cancer pathway. You understand the patient experience very well. And actually, for a lot of your QI work, you're actually very well placed to be able to see where potentially there could be improvements made and how to go about supporting that work. So just want to say thank you very much for all your hard work and your dedication. You all put in incredible hours. I'm very aware of that, and do a lot to improve that patient pathway and the experience for people who are going through a cancer diagnosis or being treated. So from everyone at the Alliance, thank you very, very much for all that you do. I don't want this just to be a one-off, but to be a real celebration of everything that you're doing. And actually, we have the lead cancer nurses from across the Alliance also wanting to express their thanks. So Claire is just going to put up a little video to show you what we all think of you. You're all amazing. So thank you very much for what you do.
Just to let you know as well, we've changed the running order slightly. So after this, it will be the BHT presentation as opposed to the OUH one. So let me just do a share. I'm doing it like this so you get a good idea where to find them on the website later.
One of the most important roles in oncology nursing is that of a cancer CNS. I have worked in these roles and found them highly rewarding. The CNS is the only person who stays constantly by the side of the patient throughout their whole cancer experience. They provide both clinical expertise and compassionate care. They're specialist roles who can signpost, make holistic assessments, and plan and deliver effective care. As well as being highly respected by our peers, the cancer CNS has a special place in the hearts and minds of our patients and their families. Together, our nursing values and our particular skill set have a profound influence on their experience, whatever the outcome.
As cancer clinical nurse specialists, you deliver care that provides a positive impact for patients. National feedback and research shows your role makes a difference to individuals on how they feel, particularly when adjusting to having a cancer diagnosis, during decision-making to treatment and the whole cancer experience. You make a difference to how each patient and family learn to cope. You deliver compassionate excellence with a focus on each individual's needs. And this is why cancer CNSs have such a positive professional reputation.
It's nationally recognised that a career in cancer nursing, and particularly in the role of a clinical nurse specialist, needs a wide and complex set of skills. The new ACCEND programme will provide a transformational reform for cancer career pathways and the associated education, training, learning and development opportunities for the workforce in an area where people care for those directly affected by cancer. We're going to ensure that the opportunities for training and development that you have align with the ACCEND programme so you can progress as an individual, a nurse and as a leader. The programme will include psychological support skills, advanced communication and specialist oncology modules. We're also going to provide a qualification in speciality. Your line manager or lead cancer nurse can advise you on how to access the training that meets your professional development plans and your career aspirations.
Every day, cancer nurses demonstrate high levels of resilience, resourcefulness and flexibility. We know the pressures are huge, but we're working across the Thames Valley to address the workforce challenges to improve recruitment and most importantly retention, both now and up to 2030. We're implementing initiatives to support and really value our current staff, such as compassion fatigue training and developing communities of practice. We're also working with you to understand how you think we can make further changes to provide effective cancer services across all of our communities. This will ensure care is not compromised and that all our staff have the appropriate skills and competencies to deliver what we all want and aim for, which is personalised cancer care. Thank you.
Delivering personalised cancer care is not only a national priority, it's one of the most important aspects in the role of the CNS. We all experience role satisfaction from supporting a person and their family during their cancer journey, recognising the importance of treating people with compassion, dignity and respect, and ensuring they have coordinated care that meets their preferences, values and needs. This is essential in delivering quality, person-centred cancer care. Oh, have I stopped sharing? Yes, I have. Ah, wasn't that lovely? So, Lyndall.
Are you sharing mine, Claire?
I thought you didn't want your one shared. We can do your one if you like. I thought you decided not to. Would you like it?
We'd love it. Go on.
Yeah.
Of course we would.
Just to say thank you to everyone.
Here she comes. Give me a moment.
Got no sound.
I don't think there's any audio, Claire.
Oh. Thank you. There's an extra button I have to press to make sure the audio works. Let me try again.
It doesn't seem to be giving any audio, Claire, so maybe I'm not meant to speak today.
It's a bit harsh. You look very nice though.
Maybe you can all read the sort of comments I'm making on screen. But anyway, all of these videos are online. If you're interested in going in, they're on the TVCA website. We do sincerely say thank you for all the hard work that you've done over the last year and continue to do. Very appreciative of the initiatives that you're taking forward, various service improvement, and I'm really delighted that the topics we have today are varied and very interesting, and I think you'll all find that you'll get something from each of the things that the CNS teams in each trust are going to share. The format for today is that each trust has a team that's going to share a specific sort of project that they've undertaken. We can take questions around that project. Everyone has approximately 10 minutes. And then at the end, we'd just like to have a good discussion around some of those projects and other things that we can take forward and things that you'd like to hear about. So hopefully that's a suitable format. What we'll do is we'll take the questions at the end of each presentation. So we'll let individuals do the full presentation, and then I'll ask you to step forward for any questions. So hopefully that's okay. And BHT have very kindly offered to go forward first. So Joe is a uro-oncology CNS supporting urology pathways, and he's going to talk a little bit about BHT work. Is that correct, Joe? Thank you very much for joining us today.
That's right. Thanks for having me. Can you hear me okay?
We can hear you. That's brilliant.
And can you understand me? That's the next thing. Other than Michael?
Yes, it's better than my Australian accent. So yes, absolutely.
Okay, so my screen should be shared. Is that right?
Yes, it is.
Yes, we can see your slides, Joan. If needs be, I can translate from Northern Irish to English. Don't worry.
Good man. Thank you very much. Just having a problem getting the slideshow to start. Yeah.
I've got it up already, Joe.
Oh, okay.
Can everyone see it all right?
Have you got the latest one with the graph at the end? That's
yes, I'm hoping so.
Brilliant. Okay.
Yeah, it's really clear as a bell.
Well, brilliant. So I'm Joe Kearney, Urology Oncology CNS at Buckinghamshire Healthcare. I work as part of a team of about 6 CNSs at the minute. It's gone up and down over the years. And I'll tell you more about what I'm going to talk about if we get to the next slide, please. So it really all started with the cancer plan in 2000. CNSs were employed to reduce doctors' hours, have a contact for the patient, improve continuity, improve waiting times, and develop the services because cancer was getting quite a bad press at that time. And so the 5 sites, or the 6 sites, sorry, not 5, of urological cancer are as below: kidney, ureter, bladder, prostate, testes, and penis. The main ones we deal with are prostate and bladder, the most being really prostate. Thanks. So the cancer plan, what was the uro-oncology nurse back in 2000? It was really sort of make it up as you go along. The job description was quite generic, but we were there to run nurse-led clinics in giving intravesical chemotherapy, doing ISC, giving bladder treatments like cystostat or QE2 cocktails for cystitis. We were sort of troubleshooting around the hospital for catheterization, difficult catheterizations, things like that. We weren't changing every catheter in the hospital as some people thought. Initially, we were sat in with the consultants in the outpatient clinics, breaking bad news. Well, the consultants broke the bad news. We took away and mopped up and gave information. We give information packages to the patient at diagnosis and their families, and afterwards when they were having treatment and after they had treatment or surgery and so on. So we were the continual link. We were key workers and a point of contact for the patient because they were left sort of out on a limb, so to speak, when they had their diagnosis. They didn't know who to contact. Well, when we came on board, they did. We were general troubleshooters for urology, and we were also there to signpost on to other agencies such as social workers, the hospice, pain team, etc., etc. And we assisted with the diagnostic tests, flexible cystoscopies, prostate biopsies. We chased MRI scans, CT scans, etc., etc. And we set up the Urology MDT. And it's, it's a different or slightly different format. Next, please. So, as Walt Disney says, the way to get going is to stop talking and start doing. So that's what we did. And then next slide, please. By 2003, we had a Uro-Oncology CNS network group across Bucks, Berks, Oxfordshire, Milton Keynes. We were all trained in IRMR. We were able to request diagnostic tests such as MRI, CT, ultrasound, bloods, etc., etc. So taking work off the doctors. We set up and ran the intravesical treatments, the BCG, the mitomycins, and the cystostats, etc., etc. Erectile dysfunction clinic was set up and run for people with urological problems only. We had to restrict it to that, or else we were inundated by the diabetic and cardiovascular patients. And then we started, or some of us started doing diagnostic surveillance and surveillance flexible cystoscopy clinics. And then instead of the consultants giving the results and breaking the bad news, we found that we were better at it and we could afford more time to the patient and their family, and it was nice too for the continuity. So we started giving results following prostate biopsies, bladder cancer surgery, or even nephrectomies and radical prostatectomies. And we set up prostate cancer, bladder cancer, renal cancer support groups. And we further developed the MDT working, and the specialist MDT are a major part of that. And we used to pre-op all the major surgeries, do holistic needs assessment and the stress thermometers. That was by 2003, so we were doing well. Next, please. And then by 2010, we had a holistic needs assessment set up for the majors, patients, post intravesical treatments. We started requesting more and more PET scans, and we were the ones that were really pushing that. The consultants just really signed them. We were requesting or putting people on the waiting list for surgery such as nephrectomy, radical prostatectomy, bladder cancer, tumor removal, etc. We started doing prostate biopsies. One of my colleagues was taught how to do trust biopsies, and then that was taken over by radiology. And then there's two of us really now able to do transperineal prostate biopsies. We started PSA follow-up clinics after a radical prostatectomy or with suspected cancer, and again taking work away from the junior doctors. A few of us have done the nurse prescribing, advanced assessment, history taken. Sorry, I just realised I don't have my camera on, and so on. And we assist and sit in and help with the medical and clinical oncology consultant clinics at both Stoke and Wickham. So we're providing a continuation of all the previous services from 2000 and these others, and we're further involved or more involved these days in clinical trials. And then next, please. So in 2022, we set up this faster diagnostic pathway. We started off with prostate because that's the majority of the work. Oh, you skipped on one. Go back one, please. You go forward. That's better, thanks. So what happens is the patients are referred in. The CNS does a telephone triage the day of the referral, organises an MRI, and if an MRI is contraindicated, a CT scan. If need be, they have a bone scan requested as well, and the CNS is able to do all that, talk the patient through it, walk them through it. Then about a week after the MRI, bone scan, CT, they're brought in for a face-to-face appointment where they're given the results. They have a rectal examination of their prostate, and if need be, then they're put on the waiting list for a prostate biopsy. If they don't need a prostate biopsy, then they have a PSA follow-up clinic requested about 4 months later, and a PSA is requested for that clinic by the CNS. It's all working really quite well, except for the bottlenecks are in the getting the MRI scans and the MRI requested or reported, sorry, and getting the prostate biopsy done. Everything else is working quite seamlessly, basically. We plan to do the same or similar for the hematuria or bladder cancer pathway, and we're just about to set that up and get it running. It's going to be the same sort of format: telephone triage, request a CT urogram or ultrasound scan, get a flexible cystoscopy requested, and then progress the patient on their pathway from that. And this is all to meet the 28-day target where a patient should be given a diagnosis of cancer or not in 28 days. We are planning, or in the pipeline is the stratified risk pathway for prostate cancer, PSA, and that'll be happening this year, I believe. I think there's somebody going to be appointed to that post quite soon. Next slide, please. So there's the statistics that Sam kindly did for me. So we started doing the faster diagnostic clinic in October, and we've had 418 referrals to the clinic. So well done, everybody. We requested 383 MRIs. We have done, what's that, about 60 odd bone scans, or requested them. And out of the 28-day target, we haven't done so well in that we've only achieved 36%, 134 patients. But that's because of the bottlenecks of MRI and getting the prostate biopsy, which was kind of tricky. We were sending patients out to an external MRI facility, and that sadly has come to an end, and we've now negotiated another external MRI facility, and they're doing about 10 MRIs a week, which reduces the waiting time dramatically. But what I can say is we've had 100% of patients had a face-to-face appointment for the results within 14 days with the CNS. So well done, everybody. Okay, next slide, please. And so in summary, the CNS team, as you can see, have developed dramatically over the last 20 odd years. There's further developments in the pipeline. It's led to a complete autonomous CNS nurse-led clinic. We don't really see doctors very much, because we can do it all for them, for the patients, I should say. The doctors are there, of course, if we need their advice, or we're on this sticky situation. That's hard to say when you're sober. The CNS team are excellent communicators. They communicate right across the board with every aspect of the MDT and beyond. The main thing is it gives a better patient experience, continuity of care, the patient seeing the same people, same faces, hearing the same voices all the time. And the CNSs are the linchpin of the MDT, basically. And as I say, we've had 100% face-to-face appointments within 14 days from referral to the faster diagnostic service. Thank you for the clap, Michael. Okay. Any questions? Was that overtime or undertime or?
Well done, Joe. Thank you very, very much for your presentation on the urology service and seeing how that's evolved over the years, and clearly your specialist skill into, delivering excellence in cancer care in urology. Also really interesting to see the work you've done on FDS, and actually it's the diagnostics that really cause the bottleneck for many in trying to deliver that pathway work. But well done what you're doing. I just wanted to ask, have you had the team any specialist training to support you with your role that you can share across?
Let me start. Flexible cystoscopy training, erectile dysfunction training, prostate biopsy training, nurse prescribing, advanced assessment, trust biopsies, Christina. I'm trying to think what else. IRMA training for the request the diagnostics, shadowing the consultants and doctors. I suppose looking around the network.
So you've got advanced skills as well as the specialist CNS skills to deliver this, and you are really delivering a very holistic service of doing the whole sort of diagnostic and treatment element, but actually making sure the patient and their needs is at the heart of what you're doing. So fantastic. I'm just aware of time. Does anyone have any questions they'd like to ask Joe now, or we can do a whole sort of group questions at the end of everyone's presentation? Please do put your hand up if there's questions. I can't see any hands up, Joe. So you've explained your role very well. So thank you very much for supporting today. We've really appreciated your input. If we now ask the OUH team to share their work, I understand they're doing some work around their prostate school and health and wellbeing. So I'm very interested to hear what they're up to. So thank you to the OUH team for stepping forward and supporting today. Over to you. Just to remember, we've got 10 minutes to try and make sure that everyone has an opportunity to share today. Thank you.
Hello, my name is Vanessa. I work at the OUH. I'm one of the uro-oncology specialist nurses here. I've worked in the scope of urology for about 5 years now, both ward-based and in the CNS role.
Oh, good afternoon. My name is Tracy and I'm the Macmillan Urology Cancer Support Worker, and I've been doing this role in the OUH for 5 years.
Next slide, please. So yes, welcome. And if you, next slide, please. Lovely.
Okay.
So we're doing so we're going to be talking about the prostate school that we lead and the health and wellbeing events for men with prostate cancer who have undergone or about to undergo prostatectomy or radiotherapy. So the aims of these events that we do is to increase their knowledge, manage their expectations, help them to recover better, and allow patients to ask questions. So with the prostate school, we hold them for the patients that are having prior to their prostate cancer surgery to have their prostate removed. And the health and wellbeing event is for men who've had following treatment with the radiotherapy, also including surgery. And it's really just about giving them the tools to self-manage, their treatments. The next slide, please. Okay. So just to give a bit of scope, we hold it at the Maggie Centre, which is our local cancer charity on site of the hospital. They very kindly give us this lovely space that we can bring our patients in, have a comfortable chat. It's a very informal environment, so that they can feel free to ask questions. And their centre is very accommodating. It also introduces them to the charity itself. So all of these men they're required to attend prostate school prior to their surgery, and to give them the knowledge, skills, confidence, and they're managing their expectations with their prostate cancer diagnosis. So it helps them to take control of their own pathway, seek assistance when necessary, and all about signposting. So topics include self-supported management, prostate-specific antigen blood testing, which measures the markers in the blood for prostate cancer activity. Important signs and symptoms, assessments, goal settings with them, managing physical, emotional well-being. And we've just opened up assigning on our patients to the OUH patient online services, Health for Me patient portal, so they can have access to their results and blood tests. Also, we introduce the stratified patient-led follow-up. It gives them the tools and information to follow this up after their treatment. It gives us a broad spectrum introduction to them. The men will be asked to complete a holistic needs assessment. And usually at these events, we have between 5 to 10 men in attendance. And it's just really all about optimizing their health and well-being. So this just really encompasses what we do at prostate school, what the patients expect to do before their surgery, the day of the surgery, taking them, from the moment they arrive to day surgery, what to expect, all the way up to the anesthetic room, what happens during their operation, giving them what to expect when they'd wake up from the recovery room. It's quite overwhelming, having all the tubes, oxygen masks, Flowtron boots, TED stockings, catheter. so that they're all aware of these things when they wake up from their procedure. Then we start giving them information of what to start doing when they get up to the ward, getting up and having walks around the ward just to get rid of the flatulence from the operation. And we give them the information about going home, fragment injections, how to look after your catheter, information leaflets regarding. It's quite an overwhelming procedure to have. So it really goes from A to Z, really, encompassing the whole pathway.
So what is a health and wellbeing? So as a team, this is how we do our health and wellbeing events. We do an introduction to the service. What is a PSA and surveillance? So it's just giving them the tools to what to look out for, and if they have any questions, if their PSA is rising, then they can just call us. They have our contact number just to call us, and then we can get them back to clinic and do a little bit more investigation of what's going on. The long-term complications of a rising PSA arising from prostate cancer diagnosis and treatment. Some gentlemen have long-term continence effects, so we can get them to talk to a urologist and get that sorted. Also erectile dysfunction. We have a men's health team particularly for surgery, that they can go and speak to them, and then they can help them on that side. We also have a sexual health group for radiotherapy patients as well. And then it's about making sure that their survivorship, if they have any issues, so they can flourish after their treatment. We also use Prostate Cancer UK, and we give them a booklet about looking after yourself, long-term living beyond having hormone treatment or having a radical prostatectomy. Signposting to other areas of support. We've already mentioned the Maggie Centre that we have here, which we're very fortunate. We also have Sober House, which we do some of the events in as well. So they're very good use. We can sign them for psychological support, any financial implications that the patient may have. We have Assistance Advice Bureau Benefits Office here at Oxford, and also in the Maggie Centre, they can support the patients as well. And in North Bicester, we have the Hummingbird Centre in North Oxfordshire. So it's at Bicester, which is also does a lot of supporting our patients in that area of Oxfordshire. How to arrange a review? They can, so we have our follow-up program that's about to start, so they get lots of questions and answers on their own on the stratified follow-up program. And then if they want to speak to a consultant, then they can ask that question on there, or they have our contact number that we follow up with, and we can arrange contact with the consultant or whoever they wish to speak to. The responsibilities, we try and put the ownership back on the patient, and explain to them, how important it is to manage their blood tests, etc., and their own well-being, and then we're here in the background to support them. So health and well-being, it's understanding their blood tests and living beyond cancer, healthy living. So we have the Here for Health team in Oxford that support us at the health and wellbeing events. We talk about emotional wellbeing, supported by Maggie's. We have the managing side effects that the CNS team can support, being able to identify signs of early recurrence, support self-management and awareness of surveillance in the patient-led follow-up online service.
So the reason why they've started these events is the national drive to make patient follow-up and more patient-centered. we focus on the health and well-being means and supported patients to take back of their control in their lives as soon as possible. And the research shows that patients' needs are, if they're met in a timely matter, and they're better informed regarding their disease management, treatments, and longer-term side effects, and how to live with these side effects, shows better outcomes. These events help reduce saturated clinics, reduces outpatient visits, and improves clinic capacity. So, you know, having our patients well informed about their journey, you know, less reason to come into clinic, less telephone calls. And of course, as I don't know about in the other trusts, but I'm sure hospital parking is the same everywhere. So it helps also reduce the environmental impacts and the traffic and parking, so that other patients, you know, can come in for their much needed appointments. Cancer, so as I said, cancer is a long-term condition, and these events are about helping patients manage with the long-term effects of their treatments. Next slide, please. Thank you.
Vanessa, just to say that your 10 minutes is up. If you could sort of wrap up the last few slides for us, please,
sure,
that'd be great.
So, as we say, we're here for health. That's essentially what we signpost. You can put to the next slide. Healthy, yeah, thank you. So yeah, it's essentially signposting the different services in the trust for healthy eating, reduced alcohol intake, or quitting to smoking. Of course, Maggie Centre as well, Prostate Cancer UK. Yep. Yeah, lovely. And just quickly some feedback from our patients. You know, as you can see, it's there. I had no preconceived ideas about what to expect, but they found it very helpful. They want us to keep doing more of these, and they found it very reassuring that we do these events. And as somebody who works on the ward sometimes, I can see a definite difference between patients who've been to our prostate schools post-op and those who haven't. It's sort of, they look more like a deer in the headlights, and the information becomes very overwhelming at once. So we seem to get some very good feedback back on these events that we do. Next slide, please. And that's it. Thank you for listening.
Thank you.
Thank you both very much for sharing your work of what you've done. It's fantastic to see these initiatives and to hear the positive feedback that we've had. I think in the interest of time and making sure everyone has an opportunity to speak, we'll move straight on to the GWH presentation around the breast service, and then we can take questions at the end. So I'd like to introduce Sarah Cooper, who is the lead breast cancer CNS there, to talk about some of the initiatives they've had running there to support. Thanks, Sarah.
Hi all. So as sort of a way of introduction, we are a team of 10 nurses. 2 of them mainly cover the metastatic service and the rest the primary side. And we're also supported by 2 patient pathway facilitators and a hold time navigator, which makes a massive impact to the team. So here at the Great Western, we are the screening centre for the whole of Wiltshire. So we have patients coming in via the screening pathway and also the GP 2-week wait pathway. And we diagnose approximately 450 new cancers, breast cancers a year. So today, really, I was going to focus on sort of things that we've done over the last year to 18 months to try and improve the service that we provide to patients. And some of it will be in the primary side and some of it will cover it into the metastatic setting. So I think most excitingly, we have introduced endocrine workshops. So approximately 80% of all patients diagnosed with a breast cancer will be put on some form of hormone treatment to reduce risk of recurrence in the future. And what we were finding is that a lot of patients were phoning us with side effects of their treatment, saying that they'd either stopped the treatment or they were thinking of stopping because they couldn't manage the side effects that they were experiencing. Often these patients were given these drugs in clinic and told by the doctor that they just needed to take them for 10 years without much of an explanation as to why they were being given them or how to manage any potential side effects. So now when we see patients in clinic who are started on tamoxifen, letrozole, anastrozole, etc., they are invited to an endocrine workshop. So we run approximately one a month at the minute. It might get more depending on how many patients we get. So we do an online workshop once a month, which lasts for, I think it's an hour and a half, where we go through why endocrine treatment has been recommended, how it works, and the most common side effects, and then they troubleshoot those side effects. It's a very interactive session, and Carrie, the breast care nurse who we've employed to kind of run the endocrine side of things, runs it along with one of our PPS who keeps an eye on the comments and the questions that come in. So it's a very interactive workshop, and it actually causes a lot of discussion. And also patients find it really reassuring because they know they're not the only ones to experience these side effects. So we hope that patients go away from that session with a good understanding as to why they're on the treatment and the importance of continuing it, with also sort of encouragement to call us should they run into any problems. If patients do run into problems and they give us a call, the breast care nurses generally are good at giving sort of quite standardised advice. But Carrie also does one clinic a week where she will speak to patients individually about concerns that they have. Most of the things that she discusses with patients in those sessions are about vaginal dryness, their sexual intercourse, any sexual problems they might have. And they tend to be the themes of what is discussed in those one-to-one sessions. I mean, we haven't audited it yet, but anecdotally, we get far less calls about patients struggling with side effects, and hopefully we will also increase compliance, which will hopefully lead to less cancer recurrences and diagnoses in the future. So that's a really exciting thing, and actually we are just about to put out an advert, hopefully, for another person to help Carrie with this line of work, because I think there's more that we could do to improve compliance in this area. Obviously, over COVID, kind of health promotion stuff was more difficult to do because we were getting out and about less. But over recent months, some of our local GP surgeries have been putting on roadshows, cancer roadshows, where they invite people from different healthcare settings to set up stalls in a village hall somewhere, and they invite their patients to come along. So I think we've been to 3 so far. So we set up stall, often with the radiology staff around in the breast screening centre, and we talk to patients that walk by about the importance of breast screening, telling patients that they can self-refer to continued breast screening assessment after they've reached or over 70, and talk to them about signs and symptoms of cancer and how to examine themselves. I went to one a few months ago now, and we spoke to probably well over 100 people between us, and it felt really beneficial, and obviously something different to do from the day-to-day stuff, which kind of, I don't know, it was quite exciting to do, and definitely kind of sort of, it felt really worthwhile. I think if we scroll down a little bit more, please. Sorry, we've done this in a poster. Oh yeah. We, at the end of last year, I think it was, all done Wellbeing team profiling as a team of nurses, and the admin team done it with us as well. So we all had to fill out, I don't know if anyone else has done it, but you have to fill out questionnaires about how you perceive yourself, and then your team fill out the same questionnaires about how they perceive you. And it was a really, really beneficial thing to do as a team. So it kind of sheds light on why we all work in different areas, work well in different areas, and how we work well together as a team, because we all have different things that we're really good at and then things that we enjoy less. It's quite difficult to explain, but it's definitely worth looking into it to kind of enhance team morale, and also to shed light on why we all work in different well in different areas. Can we scroll down a bit more, please? Thank you. So within the metastatic team, it's obviously a very busy team, as is the primary side. And with more and more oral chemotherapies or oral SATs coming out, it's been quite challenging to manage that side of things. So probably about 18 months ago now, the team set up a CDK4/6 clinic, which we run once a week, and we do it 1 week, and then the pharmacy team do it the other, reviewing patients on this group of drugs. And that actually works really well, making sure patients are getting scans on time, making sure their medications are ready to collect, making sure they're getting timely blood reviews. And because they're having that time with the CNSs, patients are also feeling well supported during what normally would be just medical appointments. And a bit further down, please. Thank you. So I know the personalised care team are probably on the line, but they have been employed about 2 years ago now, I think, to work across all tumour sites. And we've particularly enjoyed working with them. 3 times a year, we have a breast health and wellbeing day, where we put together a timetable. We run it off-site for up to sort of 30 patients. And I have to say the personalised care team do all the hard work, and we just go along, and it's really good to be there. We do sessions on signs and symptoms of taking hormone tablets, again, talking about things like vaginal dryness, which patients often don't want to talk about. We get in sometimes the oncologist to talk about some of the therapies. We get one of our breast care consultants to talk about breast examination, and then we get people in talking about, I don't know, complementary therapies and physios, health, diet and exercise, all that kind of thing. And the feedback from those days is really good. As well as that, the personalised care team have really changed, I guess, what we do with patients, because we often refer to them for their sessions that they run about, I don't know, managing fatigue, managing life after cancer, and all those things that patients really appreciate. And before we didn't have those services, it was actually all fell on us. So that's been really, really helpful. So a big shout out to our personalised care team. They do a fab job. And I think that's everything.
Sarah, we'll need to. Oh, brilliant. I was just going to say we need to wrap up.
One more thing before I leave. We've also been working with the charity Breast Cancer Now.
Is it me or is it Sarah that I think we've lost Sarah.
Sarah is
okay. So I think what we'll do is thank you, Sarah, for presenting on the breast team at GWH and some of the initiatives there. Very brave doing Melbourne and working out how the team can work well together. If we move on now to Nikki, who is going to present for RBH about the ACCEND project and some work that they're doing there. And I just want to do a big thank you to Nikki Dan as well, because actually I've heard today that RBH have had a big power outage over the weekend and this week. And so how you did your presentation over the last couple of days must have been quite challenging, Nikki, but thank you for getting this to us and sharing today.
Thank you. Yes, that was going to be the first part of my presentation to cut us a bit of slack. We've been, I think big parts of our hospital are living underwater and we have no power, and it's interesting, shall I say. But I did want to just thank our CNSs, because they are dotted all around the place. Some people are working from home, some people are working from other departments, and it's been really challenging, but everybody's really stepped up. So we're having an interesting National Cancer CNS Day, I would say. So could I have the presentation, please? Can you hear me?
Yeah, we can. Can you see it there, Nikki? It's on display.
Sorry, I can't see it. Fine, I will. Oh, good grief. Right, hold on.
It's on the background slide, if that's helpful. Or actually, we've just gone back to the CNS nursing team.
Yeah, you're on the first slide still, Nikki, so you're all right.
Okay, so yeah, I'll have to
If you move, have you got your presentation?
Yeah,
yes.
I'll open mine up and then talk through it. Sorry about this. It really is interesting this week.
So if you move
you're adapting very well, Nikki. Thank you. You just tell us when you're moving slides on your presentation, and Claire will move ours on. Okay.
Yeah, I'm just opening mine up.
Stay in sync.
Here we go. Opening it up. Right, anyway, yes, so thank you. I'm Nikki Dan and I'm the Cancer CNS Team Leader at the Royal Berks. I am here with two of my colleagues who I will let introduce themselves.
Hello, I'm Hilary. I'm one of the upper GI CNSs.
And I'm Marie. I'm an upper GI band 6 head and neck nurse.
Brilliant, thank you. Yeah, and so just a bit of background around how we work here. We have, at the last count, 29 cancer CNSs based in the Berkshire Cancer Centre, and 22 of those are employed at band 7 and 7 at band 6. Can I have the next slide, please?
Is that Nikki?
Brilliant, thank you, sorry. And then the next slide with background.
Yes, that's on.
Yeah, perfect. Yeah, perfect. So yeah, all of our CNS teams, which is a little bit different from some other sites, we're all based in the Berkshire Cancer Centre along one corridor. That actually, I think, works really well because it means we can cross cover each other, share ideas, and everyone works very closely together, particularly when developing services and looking at things like ACCEND. Put COVID down as a bit of a background thing because obviously it had a big impact on all of us and changed the way that lots of us work. But despite the difficulties, it I think has really allowed us to think about our services and how we can move forward and how we can change things. In terms of looking at the ACCEND SIPs, we know that there is an ageing CNS workforce, and just within our team over the last year, we've had a couple of people retire and a couple of people retire and return. So there are recruitment issues, and obviously that's a big part of what today is about. Within our team, and I know nationally, there's been a lot of unclear career development pathways. I know from personal experience, I've been a CNS for 20 years, and a lot of us feel that we sort of end up in a cul-de-sac. There's been a lot of focus recently on ACP development, and I think that's added to CNSs not quite knowing what to do or where to go. And again, that's another reason to develop the ACCEND framework. Within our team, and particularly around us having band 6 and band 7 CNSs, there's really been a lack of clarity over the years. Although we're based together, our CNSs work differently within their cancer sites. Some provide nurse-led follow-up or patient examination. Others work more in conjunction with medical colleagues. So moving from a band 6 to a band 7 CNS within our team has been sort of fraught with issues, and over the years things have been quite subjective, and that's sometimes caused some issues with people not feeling happy about it. So again, we wanted to bring the SIPs in and the ACCEND framework to make things more equitable. I started as team leader last January, but in a secondment, and that's since become a substantive post. So obviously there's been a lot of changes within the team. But as I say, I've worked here for 20 years in various CNS posts. So really, hopefully know the team, and I felt strongly that this was something that needed addressing. Along with Mark, as I put at the bottom, we have obviously we're very lucky to have the current UCon's president as our lead cancer nurse, and we've had a lot of support in the early stages of bringing these in, because what we've actually done, and next slide please.
Oh, whoops.
Oh, what did we do? Are we on that?
Okay.
Yeah, so we wanted to bring the ACCEND competencies in last year, but they hadn't been actually brought out until I think it was early this year. But we were able, again, I think very usefully, having Mark on board to adapt the framework into a draft. So we were able to get in quite early and start looking at them. We reached agreement with the BCC management that we could look at our bandings, and as long as people had completed the SIPs, they could then move from a 6 to a 7. We had a lot of discussions with the CNS team at all team meetings, and decided to have a sort of phase 1, if you like, looking at band 6s completing the SIPs with the aim of moving to a 7, and obviously we'll then bring it in for all of the 7s. I then as I say, there was a lot of work involved around making this equitable and feeling like they were valued. We had a team development day last year where I did a presentation called Grow Your Own CNS. Can I have the next slide with team member types, please? So this was just I put this on just to remind myself, because it just makes me chuckle. Basically, we looked at the differences in team members and where people were in their career, and then we had this beautiful slide. Next slide, please, with the sunflowers, where we were trying to demonstrate that all of the CNSs were at different stages of their career development. Next slide, please. So where are we now? And I'm gonna transfer to Hilary and Marie.
So I'm Marie, I'm band 6. At the moment, we have monthly band 6 development meetings, and they have been really helpful in helping all of us, I feel, to focus where we need to work and what we need to work on, how we can achieve our competencies in the SIPs. And it just gives us all a little bit of support as well. We know we've got the band 7s we can go to, but it also means that we can bounce off each other and work out how to do things. So that's been really helpful. We also have one-to-one meetings with our mentors. I've managed to sign some of my competencies off already with the help of my mentor, who is Amy, who's the band 7 in the team. And we are currently working on the next lot that we're going to sign off. But finding the information and also being able to provide evidence is sort of really hard work at times, especially when we're working full time as well. But we are working really hard to work on this, and Nikki's been brilliant in that she will help support us to cover our team so that we can have these meetings.
So I'm Hilary. I'm one of the band 6 in the upper GI team, and I've been working in the team for about 7 years now. And I've just started working towards the band 7, so going to the meetings with Marie and the other band 6s. So to help complete my competencies, I've started sort of compiling a portfolio of evidence to sort of go alongside it, such as patient notes and sort of information about any teaching sessions that I've been doing, and reflections as well, just that are quite similar to our NMC revalidation things, but it just all sort of keys in together really. It's quite good.
Thank you. Next slide, please. So really, future plans. I was talking to Mark the other day, and both myself and him really just want to look at providing cover for the team so they can then go off and look at the SIPs. And it like Marie said, it's just about being able to find some time to complete them. We will move to the formal ones. We just have the adapted ones that we used last year before the formal ones came in formally. I'm currently working with our practice educator to look at getting the education framework in place, and obviously all the stuff that's available through the TVCA, and just making sure that everybody is aware of what they can access. One of the other parts of this is when I came into post, I currently do the appraisals for all 29 of the CNSs and our support workers and PDPs, which is quite time consuming, and I'm trying to get people trained up and delegate that, and that will then make the mentor part of this a lot easier. And then we plan to roll it out to the band 7s and then our support workers as well. And thank you. That's our presentation.
That's brilliant. Thank you, Nikki and team, for sharing that. Very topical on ACCEND at the moment and work that we need to do. So thanks for showing how you're doing that at RBH. And potentially it's something that we could do a little bit more work on if some of you aren't as familiar with the new ACCEND competency and framework. But what I would encourage you to do is go on the TVCA website or go on the Health Education England website and do look at that competency framework and do start thinking about, as you come into your appraisal, doing your PDP, using some of those documents to try and assess yourself and have that evidence and show the work you're doing. But there is a lot of work that will be going on across the Alliance with the lead cancer nurses and how that will be rolled out. So do sort of watch this space for work on ACCEND. I want to say thank you very much to everyone who's presented today. We've heard some really interesting topics. It's fantastic to celebrate some of the great work you're doing. Do contact each other if you have questions and want to learn more about initiatives that are going on in the various trusts. Just aware of time and that some of you will have other commitments. If you can stay for a couple of minutes, if there are any questions for the speakers, do put your hand up now and we'll try and cover up a couple of those questions for people. Otherwise, the speakers are being really clear with sharing what they've been doing. Anything that anyone would like to raise? Is there anything as a CNS group that you would like to see more of, or the Alliance supporting to help you with your work, that Claire and I can take away and consider what we do and how we support you in your work? More webinars at lunchtime or not, or we're guided by you. We don't want to bombard you with things, but we're also here to support. So potentially think about that. Come back to Claire and I if you have any ideas. Mark? Oh, you're on mute, mate.
Yeah, I couldn't find my button. I'm an idiot. You would think after 3 years pandemic, I'd get it right, wouldn't you? Yeah, I thought it was a really good presentation. I think so from our point of view, from the ACCEND presentation, this sort of portfolio approach, if anybody was on the webinar this morning talking about its relevance for all of us, really, because if there's any CNSs that are working at advanced level or want to in sort of call themselves advanced nurses, and that fits with what you're doing in your job, then this approach of having a portfolio will resonate, because that's exactly what that piece of work's going to look like if you're going to do that, if you're going to work into advanced practice. And as well, if you and also having all of the SIPs lined up for the enhanced level will really help that, I think, drive that forward. So I think it all fits together quite well in the end.
Thanks, Mark. Sorry, a bit croaky today. Thank you all for your time today. Thank you for everything that you do. Real celebration of you. If you have time, join the UConns webinars that are happening. There's already been one, as Mark said this morning, another one this afternoon about 4 o'clock, talking about generalist and specialist practice, which I think will be really interesting to join. Yeah, thank you very much. And do go out and tell everyone what an amazing job it is to be a CNS and how fortunate it is to be part of that sort of patient pathway and really influence things at a time that someone really needs the appropriate support and care. It's an amazing job. And as you all know, although I know hard work, but please do share the good work of a CNS and the various specialties that you can get involved in and the various pillars of practice. It'd be great to be able to support our recruitment across the Alliance and working with such fabulous teams in each of the trusts. Thank you all very much for what you do.
Yeah, thanks very much. Thanks for sharing it, Lyndall.
Thank you.
Thank you.
Thank you.
Thank
you.
Thank you.
Thank you.
Thanks. Bye.